Hello, my name's Ian McCall and this is a little talk on keloid scars. These scars here have arisen at the site of excision of moles. And they're looking pale here just now with those little bits of blood because we've just injected some triamcinolone into them. In a keloid you get overproduction of collagen, and often the scar extends beyond the site of the original scar. In other words, the keloid overhangs the edges of the scar. Keloid scars are typically itchy. They arise quite rapidly after an excision in predisposed individuals. The itch is due to the presence of mast cells in the scar. Mast cells contain histamine, and when that's released, that's why you get itch. So keloid scars are often itchy. The other type of scarring you get is called a hypertrophic scar. Now, a hypertrophic scar is confined to the original outline of the scar tissue. Some people are particularly susceptible to keloid scars, particularly people with dark skin, African Americans. And there are certain sites that classically get keloids, and that's the lobe of the ear when women pierce their ears. But also keloids can arise from acne lesions, particularly in the anterior chest, and we'll show those just in a minute. The presence of keloids can sometimes be a familial problem as well. Now, let's just look at some other little images we may have of keloids. And we can, for instance, these are some keloids here that have erosion in acne lesions. You can see the smooth surface of the keloid scar. And this is an indication for trying to shut acne off and shut it off very quickly with the use of oral retinoids. Here's your more typical scar that's occurred at the site of a piercing in the ear, and this is the smooth surfaced keloid scar that's arisen. Now you might think, look, why don't you just shave that off or cut it out? Well, one of the problems is that the keloid often comes back even worse than before in the area where you've excised it. And if you are going to do that, the only way you'll get out of it is to do the excision, have some deep sutures in there to take any tension out of it, and shortly after your external sutures are removed, inject some triamcinolone into the scar area to try and stop the fibroblasts producing excess collagen. The other technique you can do is to have a little bit of radiotherapy to the area, but we don't really like doing radiotherapy in younger people. Let's see what other things. There's a typical keloid scar. This patient's had a lesion excised from the upper part of the arm here, and you can see how the scar is quite bulbous in this part, and then it thins down a bit. It's extending over the edges of the pre-existing surgical excision wound, and this would be quite itchy. So this isn't a hypertrophic scar, this is a keloid scar. Hypertrophic scars will sort of soften and mature in a period of several months, but keloid scars, can take years and years to soften. So you're often talking 5 years or more for a keloid scar to gradually soften. But it never returns to normal. You still have that widened area that the scar originally occupied. What else do we have? I might just show you this picture here. This is the back of the neck, and this is a condition that goes by the name of acne keloidalis. But it's nothing to do with acne, it's actually a staphylococcal infection of hair follicles here. And again, particularly in African Americans, it's an area where they often get thick keloid scars occurring when that chronic staph infection heals. The actual histology of a keloid scar we can show you here. This hyaline material here in amongst fibroblasts. This is the classic feature of a keloid scar. This isn't normal collagen, this pink hyaline material here. This is the material that you in fact see in a keloid. The fibroblasts are overproducing this. There's an increase in mucopolysaccharides in this as well, and as we've said, there's an increase in mast cells in these to make them itchy. Anything else that might be of value? Nope, I think that's most of what we'd want to show you there. So if we just go back, initially I like injecting them with Keloid A10, which is triamcinolone. I usually just use that strength. It's important that you inject into the scar itself and that you blanch it. You know, it's gone white there because we've injected into it. If you inject that underneath into the fat tissue, all you'll do is dissolve the fat tissue, and the thing will sink down a bit, but it's not going to change the shape or size of the keloid. Some people like starting with the Keloid A40, which I often find is unnecessary. I'll use the A10, I'll review them at 4 weeks or so. If it has flattened it, but not completely, I'll repeat the A10. If it hasn't done anything, I'll often go up to the A40 vial, but I'll dilute it with 1 ml of local anesthetic to take it down to A20 and use that. Some people do the opposite and go with a high concentration first, and then use the lower concentration. Just whatever you're happy with. Within keloids, there's an increase in a thing called transcription growth factor, TGF beta, and the triamcinolone injection reduces the formation of this transcription growth factor beta. Other therapies that have been tried include flash lamp lasers. They can reduce the redness a little bit of keloids, but they often won't reduce the collagen. You can activate an enzyme called collagenase, which will help to break that down, but and certain drugs have shown some effectiveness in that. The other thing you can apply is a silicon patch. That will tend to cause the keloid scar to flatten. But it has to be kept on continuously, and often for a month or more to get any sort of response at all. So keloid scars, they are a particular problem in certain families, and they can be really difficult, especially if, as I say, from the nipple line up in some individuals. That's where you're going to particularly get the scars, and over the front of the sternum. Okay, thanks very much.